In this video, we're going to discuss systemic lupus erythematosus, or SLE, and as the name implies, it's a systemic problem. So the description of systemic lupus erythematosus, or SLE, is it's a multisystem autoimmune disorder of connective tissue characterized by autoantibodies to the target nuclear antigens. So you have, well, I'll just jump here. This is kind of related to this. It's the ANAs. So if you do some blood work, you can test the ANAs as the antinuclear antibodies. And it's very sensitive, but it's not specific. If you don't know what sensitive or specific means, watch the video on sensitivity versus specificity and kind of give you an idea. So the ANAs are sensitive to SLE, but they're not specific for the disease, meaning that if the test comes back positive, well, the ANA positive, well, it means that they might have SLE, or they might have Sjögren's, or they might have, all these other types of autoimmune diseases, but it's not specific just for SLE. There's remissions and flare-ups in the disease, and it's a this is an important thing. We're going to talk about this a little bit later on, but highly variable clinical presentation. So there's a lot of different ways that patients present with SLE. The disease course and the prognosis are highly variable also. But primarily, it affects principally the skin, the kidneys, serous membranes, joints, and the heart. So who is affected in SLE? Women. Women are more affected than men, especially in childbearing years. So 20 to 50, about, this is approximately. There's a lot of, or 20 to 40, just in childbearing years. The ages of 15 to 45. So there's all kinds of numbers that are thrown out there. Robbins' Basic Pathology, a lot of this information comes from his text. So he says 15 to 45 years. The female to male ratio is 12 to 1, so it's highly predominant in women. In the children or elderly, female to male ratio is 2 to 1. So it still can happen over the course of someone's life, but it's most predominant during the childbearing years. Compared to white, non-Hispanic population, there's three to four times more frequent and often more severe in African Americans, Asian Americans, and Hispanic populations. So we're going to discuss now the diagnostic criteria. So this is how you diagnose SLE. They have to have 4 of this list. They need 4 of list. And the 4 of the list can be any time you see the patient. If they present, one time they present with a malar rash, next time they present with arthritis, the next time they present with neurological disorder, and they just need 4 of these, and then it's pretty, you can diagnose it with pretty good certainty. And so, and then you can look at all the research down here for all the criteria. So the first one is the malar rash, and I put a picture here of the malar rash. And so the rash is right here, as you can see on this patient. It includes the nose and the cheeks here, and it's a fixed erythema, flat or raised over malar eminences, and they tend to spare the nasal labial fold. So if you look in the mirror and you give a big smile, there's usually a fold from your nose to the end of your lip here. This is what's called the nasal labial folds right here. So it usually spares those. The rash does not include those, but this is the classic malar rash. The next is the discoid The discoid is the erythematosus, raised patches with adherent keratotic scaling and follicular plugging. Atopic scarring may occur in older lesions. So these are the discoid rashes here. You kind of see how they resemble a disc. That's what discoid means. And you can Google more pictures of discoid rash to kind of see what it looks like. Photosensitivity. And we'll talk about this later on, but photosensitivity, a rash as a result of unusual reaction to sunlight or tanning beds by patient history or physical or physician observation. So if the patient says, yeah, I go out in the sun and for some reason I just get this rash, and that is photosensitivity. Another thing is oral ulcers in the oral or the nasopharyngeal areas, usually painless, and it's observed by the physician when you look in their mouth. So right here you can see there's some kind of ulceration in the patient's mouth, and this is kind of a zoomed up version of that. So they get oral ulcers that are painless. Arthritis. You get non-erosive arthritis involving 2 or more peripheral joints characterized by tenderness, swelling, and effusion. So you kind of get arthritis in 2 or more peripheral joints in the limbs. Serositis, pleuritis, convincing history of pleuritic pain or rub heard by a physician when you listen to their lungs or to their heart. Or you could have pericarditis. You can have an electrocardiogram that will kind of show that. Or, you can listen to their heart and lungs and kind of see if they have inflammation of their serous membranes. You have a renal disorder. You can have persistent proteinuria. So you have protein. You have protein in blood or in urine. Proteinuria, or you can have cellular casts. If you don't know what a cellular cast is, you can Google that. I'm not going to talk about it much here. I might do a video on it later, but it may be red blood cell, hemoglobin, granular, tubular, or mixed. So you might have some kind of renal involvement. Neurological disorder, which is kind of interesting in SLE. You can have neurological problems. You can have seizures. You can have psychosis. Here's the kind of the more blood work, the hematological disorder, and you'd run blood work to figure this out. You can have hemolytic anemia with reticulocytosis. You'd have a low white blood cell count, a low lymphocyte count, and a low platelet count. So you can watch for those. You can have an immunological disorder. So obviously this is where it's specific. So if you really want to know if the patient has SLE, you order these anti-DNA antibodies and this anti-Smith reagent. And if they come back positive, it's really specific. It's highly likely that the patient has SLE. And then anti-nuclear antibody, immunofluorescent, and an equivalent assay at any point in time in the absence of drugs. So if they have an anti-nuclear antibody or ANA, that means it's sensitive, which gives you a little bit of information, but it's not a slam dunk diagnosis. So if there's an ANA or if they're specific to the double-stranded DNA antibody or the Smith antibody, then that's very specific. Now, it says in the absence of drugs, there's 2 drugs, procainamide and hydralazine. Now, you have to excuse me, I'm very poor at pronouncing all these drugs because, I don't know anybody that's perfect at it, but these drugs can induce lupus syndrome, which you get these ANA and you get some of these signs and symptoms, these presentations of SLE if you're on these drugs for 6 months. Not all the time, but sometimes you can get what is called a drug-induced lupus syndrome by being on these medications for longer then, for kind of a chronic type 6 months or more. So here I want to talk about some presentations. Okay, so if a patient comes into your office, how do you diagnose? What do you look for SLE? You have the classic presentation, which is a young female, a butterfly rash over the face. She has a fever, she has arthritis, she has pleuritic chest pain, and she talks about how, if she notices that she has photosensitivity or sensitivity to light. That's kind of the classic presentation. But as we talked about, there's a lot of different presentations. It's multisystem. You might have a little bit of one, a little bit of the other. So I kind of put together some presentations here. So a not so classic presentation, you could have a febrile illness of unknown origin. So an FUO, you have a fever of unknown origin. You have abnormal urinary findings. You have protein in the urine. You have some casts. And then you have some neuropsychiatric manifestations, including psychosis and seizures. And you just have no idea what's going on. Well, it could be SLE. Could be. So if you had a differential diagnosis list, which you're trying to figure out what's going on with the patient, you would put SLE down. So what's the classical presentation number 2? Well, you could have hematuria, you could have blood in your urine, you have renal cell cast, proteinuria, and then you could have the classic nephrotic syndrome. So you would diagnose the patient with classic nephrotic syndrome, treat the patient, and they might get better, they might not. You can also have, in severe cases, renal failure and even death, but that's in very rare cases. And again, what would be your differential diagnosis list would be SLE. Could be SLE. Presentation number 3, you have hematological derangements only. So the only thing that you can find is you have serum complement levels that are low. You have a positive ANA. You have, a low white blood cell count, a low lymphocyte count, and a low platelet count. And, maybe she has a little fever or something. So you're thinking, well, I don't really know what this is. Well, it might be SLE. SLE for your differential diagnosis list. But if you really want to narrow in the diagnosis, then you order an anti-dsDNA antibodies and antibodies to the so-called Smith antigen. So you order those tests, they come back positive, boom. You're more than likely, I don't know the specificity number on it, but from what I've read, these are very good tests to diagnose SLE. And remember that there's remissions, there's relapses, and they can span from years to decades. So they get better, then something happens where they get an episode, or there's a lot of variability in SLE. So now let's talk about the etiology and pathogenesis. So the fundamental defect in SLE is a failure to maintain self-tolerance. So you get type 2 and type 3 hypersensitivity reactions or pathways. If you haven't watched the video on self-tolerance, watch it, and that will explain how that system can go awry in SLE. You get antibodies that have been identified against a host of nuclear and cytoplasmic components. So, of course, you have a cell. Inside the cell, you have a nucleus. Well, the antibodies that your body generates in patients that have SLE, their bodies produce antibodies to nuclear and cytoplasmic components of the cell, mostly the nucleus. And so that's why you get ANAs, antibody nuclear antigen. So you get the ANAs because the antibodies are being formed, stick hold of, or use the antibody as a flag, and they attach to the components of the nucleus. Also, you can get some cytoplasmic antibodies. But antibodies to double-stranded DNA, or the so-called Smith antigen, is virtually diagnostic for SLE, which we kind of already talked about. The common tests used for detecting and quantifying ANAs are the indirect immunofluorescence and the enzyme-like immunosorbent assay, or the ELISA method. So, and this one is the best one, the indirect immunofluorescent. And so they use that technology, both of these technologies, to detect these ANAs. And you can read up more about that. The antiphospholipid, another interesting thing is the antiphospholipid antibodies are present in 40 to 50% of lupus patients. So there's an antibody, let's see here, the antibody to, you have of this cell, if I was to blow up this part of the cell right here, you would have a phospholipid bilayer. So you have these phospholipids, both sides, two-sided. And so these antibodies are directed towards these phospholipids on these cell membranes or any area in your body where there's phospholipids. So you can get these antibodies towards the phospholipids, you can get these antibodies towards cytoplasmic structures, you can get the antibodies for the nuclear components. But something that's interesting is that some of these phospholipid antibodies, they bind to a cardiolipid antigen. And this cardiolipid antigen, it's a serological test that's used for syphilis. And so lupus patients might have a false positive results for syphilis. So if you run this cardiolipid or this antiphospholipid antibodies test and it comes back positive, well, that tells you either they have syphilis or they have SLE. So SLE. So if it comes back positive, don't tell your patients that they have syphilis because it's a false positive. It could be they have syphilis, but you just have to figure that out with, more tests and a better history and physical exam. So they also have prolongation of partial thromboplastin time because of the you can watch the video on the partial thromboplastin time and explain what that is. But the platelets, these this is, let's say here, this is a platelet. Well, these phospholipid antibodies will bind to these phospholipid platelets, and it will destroy some of these platelets. So you'll have a decreased platelet count, which is thrombocytopenia, which is part of the diagnostic criteria for SLE. And so correspondingly, you're going to have this partial thromboplastin time is going to be longer because you don't have these platelets to, help with forming the blood clot. They tend to have venous and arterial thrombosis, thrombocytopenia, which this kind of doesn't make sense, but this is kind of interesting because you have a prolongation of a partial thromboplastin time, yet you have venous and arterial thrombosis. But that's just what we find. I'm not sure exactly why, but that's just what they have found. You have thrombocytopenia, and you have recurrent spontaneous miscarriages. So this might be another presentation where the patient says, yeah, I keep having all these miscarriages, and that could be because they have SLE. So let's talk about some of the pathogenesis of it. So the pathogenesis of SLE is increased generation or defective clearance. So you have an increase or a defective clearance of the nuclear antigens released from apoptotic cells. So remember what apoptosis is. Let's say this cell right here gets a signal from somewhere that it needs to go it needs to undergo apoptosis, or it receives a lack of growth factors, which then will cause the cell to undergo apoptosis. So this is apoptosis. And what happens is this cell, there starts to be apoptotic buds, apoptotic bodies, and there's a little piece of the cell that breaks off. And this is an apoptotic body. And you can watch the video on apoptosis versus necrosis and to kind of to understand more about this pathway. But so as these cells are dying, there's a defective clearance or there's an increase of generation of nuclear antigens released and a failure of a T and B cell tolerance to these self-antigens. So usually these apoptotic bodies, this cell undergoes apoptosis and it will just die. It will just die out. These components will get reabsorbed somehow, and you can either reuse them or you'll excrete them. You'll get rid of them. Well, the T cells and the B cells somehow have lost their tolerance towards these nuclear antigens, and so then that's how you start getting, this is kind of the pathogenesis. And there's two main components. Now this is the current theory. This is a theory. We're not exactly sure, but this is a theory. So there's genes, or there's a genetic. Sorry if you heard that screaming. My daughter wanted some milk. Anyways, so there's two types of components to this pathogenesis. There's the genetic component, which is the class 2 on human chromosome 6. Where you can talk about this, review the self-tolerance video and we'll talk more about that. But there's the class 2 gene, or part of the chromosome. There's the complement. There's other genes that you get from your mom and dad that provide a susceptibility to this defect in self-tolerance. And so there's kind of that component to this paradigm of pathogenesis. And then there's environmental triggers. If you have, sex hormones, that obviously females, that because there's a female, there's a lot of females that have this condition. It's more common in females. There's something going on with the sex hormones and the UV. When you get exposed to UV, the sun damage, they think that, well, the UV is killing some of these skin cells, and that is just when you get a sunburn or some sun damage, you have an increase of cell damage in your skin. So then naturally what's going to happen is you're going to have more of these nuclear antigens floating around in your blood because, these cells are, dying. So cell death, and that corresponds to more nuclear antigens, which then causes cellular apoptosis, and that causes nuclear antigens or other proteins. And then because you've inherited this gene, then these antibodies are going to attack those proteins. And so then you have activation of T and B helper cells that are specific to these self-antigens. You have the IgG autobody production, and then you have these immune complexes and autoantibody mediated tissue injury all over your body. And so that's kind of the nutshell of SLE. And we are going to talk about in the next video kind of the morphology. If you look at the kidneys, the skin, the kidneys, serous membranes, joints, and the heart, kind of what does it look like on a microscopic and a macroscopic level. So we'll see you in the next video.